Hi, I'm Tamika Smith with Florida Voices for Health. Today, I'm joined by Dr. Zinzi Bailey, a research scientist who focuses on health equity issues at the University of Miami, and Dr. Temple Robinson, the CEO of Bond Community Health Center in Tallahassee. Thank you both for joining us today.
Thank you.
Today's event is hosted by Medicaid Matters Florida. We're a coalition of advocates, providers, lawmakers, and Floridians working to protect and expand access to care for low-income Floridians. Now, COVID-19 has undoubtedly stopped us all in our tracks. The way we go about our business every day has changed, but there are some realities that remain the same. One of those is racial inequality and health outcomes. There's a saying in the Black community that when white America catches a cold, Black America gets pneumonia, which points to the experience that African Americans have with the healthcare system. Access to care and treatment while in care tend to be issues. And yes, we're seeing that inequality is showing up with COVID-19. In Louisiana, more than 21,000 people have been infected with COVID-19. African Americans comprise 70% of the deaths, but only 33% of Louisiana's population. The small city of Albany, Georgia, that county has more than 1,200 confirmed COVID-19 cases. 78 people have died. And according to early reports, 81% of those who have died are African American. And then in Michigan, African Americans make up 14% of the state's population, but currently they account for 33% of its reported infections and 40% of its deaths. So today we're going to talk about racial equality that exists in America from a historical perspective, and then what we see going on today with COVID-19. And then we're going to talk about what can be done to address these inequalities. Although our conversation today is pre-recorded, we will be live. We are live in the comment section again. If you have any questions, we will be answering them in real time. So let's go ahead and get started. Dr. Bailey, I'll start with you. As you've looked at some of the new data, can you tell us more about the research that you're doing? What have been some of the differences in outcomes between communities of color and other communities during the pandemic?
So before I really get into the work that I do, I want to give the context for that. And so while COVID-19 is largely indiscriminate in its transmission, its propagation within a society that's steeped in structural racism will undoubtedly, as we are already beginning to see, lead to disproportionate impacts among marginalized racial and ethnic groups in this country and in the state. So this disproportionate propagation is heightened by an uncoordinated national response. Oftentimes our state response is uncoordinated, and that interacts also with test rationing. So we have two main facts that I think are key in thinking about this as well. One is that the identified cases only represent the tip of the iceberg. Some experts believe only about 12% of the actual number of people infected are identified and, through testing and confirmed. Further, there's other research that estimates that between 44 and 48% of the secondary cases of COVID-19 were contracted while the initial cases were asymptomatic. So if we take those two findings and apply an equity lens, we can expect that undercounting is going to be more pronounced in marginalized racial and ethnic groups. And it's going to play out in similar ways that it's played out in previous epidemics. However, a lot of this can't necessarily be revealed just yet, as our data is insufficient, right? We're not disaggregating universally on race, ethnicity, on socioeconomic status, poverty, other things like that that are going to be key to assessing what our response needs to be and how we're going to move forward. And hot off the presses, the CDC is now newly reporting demographic data on COVID-19, but the race and ethnicity data is missing for fully 78% of those cases, which I think is a national disgrace, because there should be more attention paid to this data and these data, and essentially these things are supposed to be reported on death certificates. So even with this information that we have, nationally, we have inadequate data released to assess the true impact of the pandemic across different communities. And Florida is among those states not necessarily releasing that data on race and ethnicity. And that's key. You just highlighted some really key disproportionate impacts regarding death. Of course, all of this is going to be very preliminary, but those disproportionate impacts are relatively damning, right? You know, if we think about southern states, many of which you referred to, many have not accepted Medicaid expansion, so there are likely even greater disparities due to that, that factor. And the main question for me is, how did we get here, right? And so we know that there are multiple levels of factors that are driving what we're seeing. A lot of them are operating through structural racism, and Black Americans and other people of color are experiencing higher burdens of, you know, we already know that they have higher burdens of pre-existing conditions that, you know, put us at higher risk for COVID-19 complications. We also know that Black Americans and people of color experience structural barriers to healthcare access, including residing in states with no Medicaid expansion, drastic cuts to public health infrastructure, and the unraveling of our national safety net. However, like confirmed cases, this is just the tip of the iceberg, right? COVID-19 is laying bare these structural inequities that create very different conditions in which we live. We can call them social determinants of health, social determinants of health inequities, but whatever we call them, they impact how we live day to day, right? You can say that washing your hands and social distancing are cheap and accessible, but that neglects to consider that prevention is never a one-size-fits-all. Black, Indigenous, and other people of color are overrepresented in racially and economically segregated communities that often provide substandard housing conditions, unsafe or limited water, I'm thinking of Flint, and crowded housing conditions that make hand hygiene, self-isolation, and quarantine very challenging, if not impossible, right? Going beyond that, staying at home like I am and social distancing is a luxury, although not very luxurious for most of us. With the exception of Asian communities that were largely stigmatized, especially at the beginning, exposure to people traveling from areas with COVID-19 outbreaks for people of color was initially likely a little low, a fact that impacts access to testing to this day. However, now people of color are more likely to be less protected essential workers, mandated to work and interact with the general public. Yet that risk is not translated into access to personal protective equipment and access to testing, right? Modifying our test criteria. However, if you live or work on Fisher Island, for example, one of the wealthiest neighborhoods in the country, tests are bought for you and are easily accessible, right? Severe inadequacies in our testing and surveillance disproportionately burden communities of color. People have been turned away, people are not going in because, you know, either they don't have insurance or they think it's not worth it, or they've had negative experiences in healthcare already. So we're seeing a lot of that, but that doesn't take away from the fact that our criteria do not accurately capture risk, right? How do we capture essential work where we don't know the COVID status of those coming and picking up a prescription from the pharmacy or food from, you know, a drive-through, et cetera? And how do we account for undetected cases in our neighborhoods where testing is really, really low when people are asked how you interacted with a known case, right? So that reliance on hospital-based drive-through testing, all these different components advantage those with more resources. And if people are lucky enough to get a test, there's a juncture where providers and health systems have to decide whether they're going to get admitted to a hospital, whether they have access to a ventilator or other life-saving resource. Here's where pre-existing conditions, criteria for prioritizing key resources like a ventilator, and pre-existing implicit bias disadvantage people of color. Further, when we think about hospitals in segregated neighborhoods, they're often less resourced with equipment, personnel, financial flexibility, and people of color have more pre-existing conditions and at younger ages, increasing the risk for complications. So with that backdrop, part of what we're doing at the University of Miami Miller School of Medicine's Sylvester Comprehensive Cancer Center is partnering with Miami-Dade County to quantify the extent of COVID-19 infection in the county using antibody testing. Antibody testing is not perfect, but with this seroprevalence study, we can better understand what's happening locally, right? The proportion of residents already exposed to the virus, the proportion of asymptomatic individuals who are positive, and the impact of social policy on the epidemic curve. And more importantly, over time, we can estimate how COVID is impacting different communities and how much those estimates differ across communities. This can be used to help mobilization efforts among our community leaders and members, rather than just like sitting and admiring the problem. And this means identifying where there might be disproportionate impacts of test rationing, et cetera. And based on the initial data, there's quite a bit of variation. And in the absence of widespread equitable testing, this is a huge step in the right direction.
Wow, that was a huge lesson for all of us. Thank you very much for that. And it sounds like with the study, you've already jumped right in. Like you at the university, partnering with the community, you've started to find a solution already, which is remarkable. So thank you very much for sharing that with us. Can you talk a little bit about some of the historical context of the trends? Have the differences that you talked about, have they been generally true in the past?
So I think the historical context that is really necessary to understand these kind of initial data that we have and approaches are grounded in our national commitment to racism, right? We often think about racism across different levels, thinking about internalized racism, which is, kind of thinking about racial superiority and inferiority experienced within an individual, interpersonal racism, what we usually talk about when people are interacting with one another. We think about institutional racism, namely the discriminatory policies and practices within and between institutions. And we think about structural racism, which focuses in on the totality of ways in which societies foster racial discrimination, namely through the mutual reinforcement of inequitable systems. So that can be housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice. How do they interact with one another to disadvantage certain groups? And so while this is going on, it reinforces discriminatory beliefs, values, and distribution of resources, which then come together to affect the risk of adverse outcomes, as well as normalize adverse health outcomes among marginalized racial and ethnic groups, right? So that is a whole system at work that then COVID-19 comes in to interact with, right? And to better understand how structural racism operates, I'll just highlight a simple example that we're likely all familiar with, racial and ethnic residential segregation. I've already mentioned a little bit about that thus far, but racial and ethnic residential segregation in the United States seemingly operated through the housing sector, but it popped up and facilitated other institutions and sectors in their discriminatory policies, whether they were colorblind or color explicit. So, you know, we hear about redlining of a lot of the neighborhoods in the United States where there was denial or limitation of financing or refinancing in certain neighborhoods based on the racial and ethnic composition. So green areas were the best. Essentially, the exact language is lacking a single foreigner or Negro, where red areas were infiltrated by Black residents or other undesirable populations. And they were largely ineligible for federal housing administration backing, right? And redlining and this segregation was not just a clustering of people. This practice concentrated investment in white suburbs, which simultaneously segregated people and hastened the decay of the inner city. It operated along, complementary to restrictive covenants, which were enforceable agreements on how land could be used. For example, restricting to white residents, disparate impacts of zoning and land use policies, and discrimination in the historical and current rental and mortgage markets. So it sets the stage for what we've come into, which is a colorblind distribution of resources over time. So we have a distribution of environmental hazards, inadequate healthcare, inadequate education, state-sanctioned violence, and municipal disinvestment, right? And through structural racism, that segregation, redlining, and benign neglect are teamed with restrictive covenants, zoning, neoliberal market forces, as well as things like a discriminatory Social Security Act of 1935, which denied retirement benefits to professions that were occupied predominantly by people of color. Other policies like unfair school funding, concentrated policing, we could go on. That happens over the life course, across generations, and across domains to produce these kind of differentials in intergenerational wealth, education, income, exposure to concentrated poverty, and exposure to quality hospitals, schools, and jobs. And so this is the historical context that drives health inequities in the United States. And I want to highlight that this historical context impacts our contemporary public policy and impact the lives of all Americans. So for example, starting in the 1980s under the Reagan administration, there was a systematic dismantling of Great Society programs, which is the basis of our social safety net. Since then, American life expectancy has pulled away from those of other wealthy nations. At first, it was primarily impacting marginalized racial and ethnic groups, as seen by a widening of the gap between Black and white life expectancy over this time. However, that was kind of normalized for a few decades, right? And it comes to, then fast forward, we come to 2015, when we see dips in white life expectancy, such that those Black-white life expectancy curves seem to narrow again, but not in the way that we hope they would, by everyone doing better, right? And although that has not been normalized, and it's now a cause for alarm, whites still experience an overwhelming health advantage over Black and Indigenous people, clearly noted in our data. So thus, we are really seeing that COVID-19 is consistent with our history, but can be impacted by the policy changes, the choices that we make now.
Okay, thank you for that, yes. All right.
And I think I've done a number 3. So.
Okay, I'll shoot to Dr. Robinson. Dr. Robinson, as a physician on the ground, what do you think are some of the factors that account for some of the differences we see in the racial differences, and what role do you think racism plays?
Well, I'll couch my remarks around what Dr. Bailey has been discussing, and she and I spoke about this a little bit offline. In medicine, we are always dealing with something called a patient's allostatic load, ALLOSTATIC. Allostatic load, we consider it, think of it as a constant background noise. Or let's say you have a chronic pain and you hurt all the time every day, to the point that you just hurt all the time every day. And so think of the type of stress that would give a body if they hurt all the time, every day. So when we start talking about racism and generational racism, then we look at this load that persons of color and grandparents and great-grandparents have been bearing for years and years. And it essentially wears a body down. It wears you down physically. It wears you down psychologically. It increases what we call stress hormones, which also then increase weight. It's hard to maintain weight or hold weight. It puts the body in a state of chronic inflammation at all times, especially with those diseases such as diabetes. And it attacks the immune system. So you are tensed at all times. You've been tense so long. The community has been tense for so long. You don't even realize you're tensed anymore. But this, along with COVID now, has become, well, actually it was a deadly combination in the absence of COVID. But when you add an infectious disease on top of this, it is truly a deadly combination. You know, you listen to people on TV or radio talk about hypertension, diabetes, and obesity. And they say it so fast as if it is one word. When we were in preschool, we used to sing the alphabets and we get to elemental P. Well, none of us could read. But once we could read and we saw that L, M, N, O, P were separate letters of the alphabet, we realized that each meant something and each stood for something. So if you have a patient who first has the allostatic load of just being born a minority in this country, and then you add the other letters, hypertension or diabetes or obesity or any type of immunocompromised problems such as HIV or rheumatoid arthritis or lupus that disproportionately affects our population. And now you've added an infectious disease that is airborne or air transmitted. I shouldn't necessarily say airborne. It is a horrible combination, and it blunts the immune system and it blunts your natural defenses.
Okay, thank you for that. It's almost like if it wasn't COVID-19, if it was something else, it still would lay on top of.
Correct.
These historical and systemic. Yes, ma'am, go ahead.
No, because it's always something else.
Right.
So until, as Dr. Bailey was saying, until we can peel away at some of these layers of stress that's putting on the physical body and the psychological body, it will always be something else. When one spends their whole life literally and figuratively looking over your shoulder, is something about to happen to me? Is someone about to further disenfranchise me? Can I get into this door? Am I going to get into a locked door here? How are my children? Am I safe at home? Am I living in a food desert? All of those things. Can I trust what the doctor says? Can I trust my own doctor? Can I trust the pills that were given to me? When you live this life and you worry about employment and doing the right thing, it is a stressor. And all of us know if you overwork and work too hard and you say, yeah, I don't understand. How did I catch a cold? Well, you caught a cold because you were doing everything but taking care of yourself.
Right, right. Thank you. Thank you. So let's talk a little bit about some of the systemic barriers to access that you've seen play out, Dr. Robinson, especially in a more rural area, like the Tallahassee, the Panhandle area. And then I'd like to hear from you also, Dr. Bailey, in terms of how you see that in Miami and more in a larger city.
Well, I know you've seen all over the country drive up, and they call them testing centers, but really very few of these areas are doing testing. This is specimen collection. So you see a lot of these drive up centers. Well, you aren't seeing drive up centers in rural areas. Rural patients and patients living in the urban area have significant transportation problems. You can't walk up to one of these centers unless you first seen your primary care provider and you have an order, okay, an order to get the lab, the specimen collected. So you can't use a drive-up center if you don't have anything to drive. Another problem that we're seeing, another barrier, is the information void. Everyone now, because of the social distancing, has gone to using telemedicine, if you can, to help people with mental health counseling, for primary care, if you really don't need to lay hands on someone. But if you're in a rural area and you don't have broadband, there is no Wi-Fi, this is a great barrier. And we're actually starting to purchase small hotspots for patients that we know have no Wi-Fi access, so that the medical provider can communicate with them in areas where they don't have access. So a lot of good ideas are good ideas until you realize, that's not such a good idea.
It doesn't work for everybody.
Exactly.
Right. Okay. And Dr. Bailey, what are you seeing in the Miami area?
So I see similar systemic barriers to what Dr. Robinson is highlighting. I think it just plays out in slightly different ways, and we have our own specific context, geared towards the city life, right? Prior to COVID-19, Miami has had the distinction of being the poster child nationally for rent burden. So the relationship between how much people are paying for rent to what they're earning. So we have the highest levels of people paying over 30% of their income, over 50% of their income on rent, on living. So mortgage, rent, all of those things. We have heavily policed areas, and we incarcerate quite a few people from marginalized racial and ethnic groups. So there's an element of that where we can call attention to how quickly COVID can spread in a congregate setting, right? So we're talking nursing homes, jails, prisons, all of those things. And we have to be talking about those kinds of settings. Largely, jails and prisons are not places where you can easily access soap, access water, have hand sanitizer. They're largely banned. I'm not sure what their mask policy is now. People are usually in crowded settings. There's no opportunity for social distancing. And if we say, there's going to be social distancing, that will look like solitary confinement for everybody, which is not a great thing. And because of how we incarcerate, that is largely falling on Black and brown bodies. We have huge income inequality issues, which also allows some people to purchase access to testing and others without. I think in contrast to rural areas, I think they've been opening more community sites in Miami where people can, again, drive up if they have a vehicle. without a doctor's order necessarily. So there's some places that you can do that. But what we also see is that places like Fisher Island bought tests for everybody. And there's one hospital, Larkin, that charges $150 if, you know, for a test. And so if you're willing to pay that out of pocket, then you can also get a test. So we have those kind of differentials, large difference in access. Because there are also communities where there's minimal testing and there's probably more social interaction. I think there's similar issues, but playing out in different geography.
And neither of us have discussed the homeless population.
Oh,
and
yes.
This has been very, we're very worried about this population. We have some homeless that are housed in various shelter settings. So we've had to disband them and get folk moved into hotels and so forth. But we still have a lot of homeless that are out in the community. They're out under the bushes. They're in the parks at night. They're in close confinement. It's going to be a huge problem. I know we're talking about COVID and the testing situation and the lack thereof. But my other big concern is, well, I have two. One is the quality of the testing that's being done. So we talk about the antibody test, and a lot of people are saying, well, if you're IgG, and for those of you on the radio, you have an IgM when you first get something, an IgG when you've had something. But we have to remember that in the HIV world, one of the things we do to see if someone has been exposed to HIV is an antibody test. Now, HIV replicates differently than COVID, and this is very new to us. So we don't know if the IgG test means you had it and it's not growing in you, if you will, or if you had it and it's all gone. So there's a lot to be learned, and we need to learn it quickly so that we can use these test results to our advantage. What we do not have now, and we really need, are point of care, accurate, rapid testing. We have people on the front line, and I don't mean just healthcare workers. It's a no-brainer that your healthcare worker, you need to know whether you're Typhoid Mary or whether you don't have COVID. But folk at the grocery store, the gentlemen that are picking up my trash, they're picking up my garbage and everybody else's garbage, and they don't know what garbage they're taking home to their families. The daycare centers in the Tallahassee area, hear me, daycare centers with little children in them are still open.
Right.
The majority of people that are manning daycare centers are people of color.
Right.
They have not been tested. The children haven't been tested. The children are living with grown people that are going to work every day. That's why the children are in daycare centers. So without accurate, rapid, and repeated testing, we don't really know what's happening, because if you're negative today, that doesn't mean you're not going to be negative next week. Right. And until we can get the majority of people tested, we don't know what we're dealing with here. You're talking about the tip of the iceberg. I think we're seeing the tip of the tip. I really do.
Dr. Robinson, what does it take for us to get there? We have the rapid testing. What will it take? Because I agree with you, the people who are picking up the garbage, the essential workers that we see working in the grocery stores and at the dollar stores, that we are thankful for them to be there, and everyone's professing their thanks for them. But what does it take for them to have access to testing?
Well, this is not my expertise as to how the tests are made. I do know there are many hospitals that say they're ready. They can run 1,000 tests a day, but they can't get the reagent the thing that you test the test with. They can't get the reagent to run the test. Some of the reagents are made in Italy, some of it's made in China. So we have a supply problem. We probably also have a logistics problem, and I'm not going to be too political here, but I think we have a logistics problem, and some of it is a problem from the manufacturer side. So there are a lot of reasons why, but I think it is very interesting that, as Dr. Bailey said, folk on Fisher Island, I don't know if they had the fast test or the slow test, that those with means can figure out a way to get it. People are talking about opening up, and I love Major League Baseball, but opening up Major League Baseball and everybody that's associated with every team, as well as everyone that's working the fields and everything, get a test daily before they can get on the field if they open up the baseball season. Would it be, if you can do that,
right,
you can test the average Joe.
Okay, thank you for that. So Dr. Robinson, what are some of the things that people with chronic conditions, the LMNOP conditions you talked about,
Yes.
what should they keep in mind during this time of social distancing in order to stay healthy?
The first thing, don't let your guard down. After, we went on these shutdowns for 2 weeks, and after about 10 days, folk got itchy and said, I think I'll just go here. I'll run over here and pick this up. Old habits are hard to break, but I really, really want to tell the listeners, beg the listeners, don't let your guard down and get complacent and start doing things you shouldn't do. That is, you've stopped social distancing, that you say, well, I'm not going to wear the mask right now, or I'm going to go and visit Aunt so-and-so. I think she's all right. I think I'm all right. Please don't do this. If you can get medications filled for 90 days, go ahead and get that done so your chronic ailments don't get out of whack, if you will. If you're diabetic, check your blood sugar several times a week. Keep a log, then call your healthcare provider with the readings, because there are times that frequently we can make dosing decisions over the telephone. And if you can, go outside, but keep your distance from others. You've got to get outside, get some air, get some sun, but keep your distance from others. But the main thing is, don't let your guard down and become complacent and slip back into doing those things that we know we can't afford to do now, so we get this virus under check.
Okay, thank you. So we see that our healthcare system is obviously working very hard to keep up with the surge of patients. What do you recommend for people, particularly in vulnerable communities, who may need routine care to manage their conditions?
Well, several things. We talked about telehealth, but the first thing is call your medical provider, reach out to agencies that you may have not been comfortable using in the past. And I'm going to first start with telemedicine. If your doctor says, I want to talk to you over the computer, I want to talk to you over through your smartphone, don't be afraid to do that. And your doctor or your nurse will walk you through how to do this on the smartphone so that your provider can see, they can help you. Ask your provider to say, how can I stay safe when I come into the office? And your healthcare provider can walk you through, this is the number to call. We have patients wait in the parking lot until 5 minutes before their visit, so they're not in the waiting room. So they're going straight to the exam room. We put masks on them before they come into the office. So call your provider and say, what do I need to come in? I can't do this over the phone. I've got a rash. I've got a new lump, bump, or something that I need you to see. What is the safest way of doing this? And you'll feel comfortable, more comfortable, if you are informed how to do this. And a lot of community health centers are using their mobile units, and I want people to be encouraged. When you're in a mobile unit, it's just like you're in the doctor's office. So don't be leery about going to a mobile unit. A lot of the mobile units also have telemedicine. So sometimes you may just go to the mobile unit so you can use the telemedicine system that is speaking with your doctor that's back in the office. I know it sounds weird to say I'm going to go into this. Someone told me the other day, you mean I'm supposed to go in this wagon to get an exam? Yes, I need you to go into this wagon to get an exam. But this is what we need to do to stay healthy. If you don't take care of those elemental P things, hypertension, diabetes, and all of those chronic illnesses, you won't have to worry about COVID, because the problem will end up being end-stage heart disease, renal disease, heart attacks, amputations, infections that we can't cure, and so forth. And I don't want people to forget about your mental health, your levels of anxiety, your stress, your coping mechanisms, and not lean on, overly lean on those things that we know will get us into trouble. When I say us, I mean all of us. I don't mean just people of color, that will get us into trouble down the line. Do not self-medicate. Call a healthcare provider and work it out, talk it through, and not be embarrassed to say, I'm not dealing with this very well, because the stigma of reaching out for behavioral health services and counseling services is huge, and it is a barrier to our well-being and our psychological and mental health.
That's absolutely right. And thank you for mentioning that. I don't know, this has been a huge change in everybody's lives. Yes. So everybody is adjusting and taking some time to adjust. Yes. To all of the changes. So yes. That's definitely the mental health. Take care of yourself, definitely. So Dr. Bailey, from your perspective, what are some of the things being done to focus on disparities in terms of research, your research and the work that you're doing, and what more can be done?
So I think a lot of people have been mobilized to try to create new community testing sites, or specimen collection sites, as Dr. Robinson said, have been trying to get messages out to our communities that might not trust certain people to communicate messages, may not hear them, may not have access to the venues that or channels that are communicating more extensive messages. So I think there's a lot of mobilization in that way. What we don't have right now, which we need to still think about, is coordinated responses. So whether that's on a county level, on a state level, a national level, we need to be working more towards having a coordinated response. Maybe it's even a regional level. So a lot of states are communicating with each other and planning together, and having not only different geographic entities, but also having like different sectors communicating with each other, different providers communicating with one another, the Florida Department of Health communicating with local universities, health systems, etc. There's ways that we can make our resources synergistic and make them work for all of our residents. With regard to the specific disaster, one of the key elements that we've been talking about more and more is that access to testing. So if I had a wish list, then I would want to see equitable access to free universal testing, right? Universal testing that allows people to equip themselves with the knowledge to seek care, isolate if they can do that, seek shelter if they can do that. One way that could be helpful is in the similar ways that some first responders are being accommodated, literally accommodated, to reduce the likelihood of conferring risk to their families. I think this should be something that is looked into to, to be available for people who need better shelter to quarantine, especially those in congregate settings, like whether it's nursing homes or homeless shelters or prisons and jails who are being released, like those sorts of things. If there are more ways to get those people shelter, that also contributes. Also, we need to consider those areas experiencing structural vulnerability to COVID-19, and think about how we move forward without stigmatizing our communities. In many epidemics in the past, people of color have been labeled as vectors of disease. And I think we have to be very careful about how we move forward and talk about these disparities and contextualizing these disparities such that we don't do that again, right?
Exactly.
I think that has happened in a lot of Asian communities thus far, and there's been a lot of hate and hate crimes that have been perpetrated, right? And I think I'm going to get into a little bit of shaky ground, but I would say that there needs to be something like an immediate eligibility for Medicaid if people are uninsured due to job loss, right? And try to limit that bureaucratic red tape. So, you know, related to that, there needs to be investments in the infrastructure for applying for unemployment benefits and getting through to those systems. And if that is invested in, it could facilitate not only those benefits, but also facilitating conversations about Medicaid eligibility. We also need to think very carefully about how we're utilizing police and National Guard to enforce stay-at-home orders. Very preliminary evidence is showing that certain communities are being cited a lot more, but what's not also reported is that those communities are being monitored more, right? There's disproportionate impact. And maybe we need to be leveraging different people, maybe community health workers, others who are more trusted in communities and not the kind of warlike resources that we have, and communicating risk. And then I think finally, we should think about how we can reduce our jail and prison populations as our packed prisons and jails make us more vulnerable to the next pandemic. So.
Absolutely.
Right, yes. So you touched on a topic, the Medicaid expansion, which we've done a couple of talks with Florida Voices in terms of how that would impact our state. I think the number that was used the other day was close to 800,000 Floridians would be able to get care and have access to care if Florida expanded Medicaid. So right now in Florida, most adults, you have to have a child under the age of 18 to get Medicaid. As soon as your child is 18, your Medicaid ends. And so that leaves just so many people in the Medicaid gap, and they're not able to see a doctor, have access to doctors and to medications as well as a result. So Dr. Robinson, can you talk a little bit for us about how you think Medicaid expansion would help, if you think it would help Floridians have access to care in the case of the COVID-19, but in general and overall, how would it be helpful for Floridians?
Well, that's a loaded question, but we know Medicaid expansion is vital. And I'm talking about full Medicaid expansion. And I'm not talking about medically needy share of cost Medicaid, where you have to meet a $1,500 deductible every month before your Medicaid benefits even kick in. And we know that a healthy society, physically healthy society, feeds back into the economic strength of a society. So sometimes Medicaid expansion isn't taken on by a state because they're worried about the economic impact. But if your citizens are healthy, then your citizens can work and they can pay taxes and they can do other things that will make the whole your whole society healthy. You know, the insurance companies waived co-pays for COVID treatment, some of them did, and COVID testing. And the federal government made a huge deal about this, and those people with insurance greatly appreciate it, but it did nothing to help uninsured patients. So we've got to expand Medicaid, and I'm talking about expanding full Medicaid to persons that are uninsured and cannot get health care otherwise, cannot get health insurance otherwise. And feeding into that, and you spoke of the 800,000 people that may benefit. I think going forward, one of the things we have to continue to stress is the importance of something as simple as taking the one-page census this out. It's a very short census. I was a little surprised by it because in the past, when I used to take the census, it asked you many more questions and many more in-depth questions. But the census is coming out, and I encourage people to participate and not be afraid to take the census because it directs funding. It directs vital state and federal funding to your area, and especially our areas of need. Areas where predominantly minorities live were substantially undercounted in 2010. And once those numbers go in the census system, they last for 10 years. When people go to write grants or make projections for funding or make projections for the future, they say, well, it's 10 people living in this community now, and they'll put a formula to it and say, you know what, in 5 years, we think there are going to be 15 people there. But if it was actually 100 people living there, but only 10 took the census, then when you start doing projections for funding, for schools, for community health centers, for Medicaid expansion, for other dollars that would be earmarked to help minority populations, you're starting behind the 8 ball if you don't have the data. So I'm asking people, one, to take the census, count everybody in your house. The census is not just the person who is mailed to. Read the questions carefully. Don't be afraid to answer so that hopefully some of this data can be used for good. Medicaid expansion is vital. I don't know how we beat down this door to get this done. I don't understand how people can sit in the State House and look at your neighbors or the people that are working around you and know that they don't have access to health care because something as simple as using the federal funds that are already allocated to the state hasn't been done. I don't understand it, and I'm sure there's somebody that can explain it to me, but I'm not one to waste money, and this was a true waste of federal assets that were earmarked for our state and for the residents of our state. I still don't understand why.
Yes, I'm right there with you. Dr. Bailey, do you have anything you'd like to add on that point for Medicaid expansion?
I think that Dr. Robinson really touched on the major elements of it. And I think there's points where we can be creative about the policies that we move forward with and how we invest in the infrastructure of our state government, our local governments, to be able to get resources where they're needed. So I want to thank you both.
Yeah, and I'd like to say, sometimes I look into the eyes of folk and I speak with people, and Dr. Bailey will appreciate this. I get this look of, well, Medicaid is for them and those until they become them and those and realize, oh my goodness. I had some patients when the Obamacare first rolled out, and I'm going to quote her in her vernacular. I don't want no Obamacare. I don't want no Obamacare. Then this lady had a heart attack and needed a quadruple bypass and various other things. And while she was in the hospital, the case managers at the hospital realized that she could qualify for Obamacare. The hospital wasn't going to incur all of these expenses, so they signed her up for Obamacare.
Yep.
When she got out of the hospital, stitches hadn't even healed. She came to me and said, I thought I didn't want no Obamacare. I'm so glad I've got Obamacare. Well, it is the same thing with this COVID virus. This virus is not going to just sit on one community.
Right.
It's not just going to hit them and those. Them and those are taking care of you and yours. And it's a virus. And if I can get it, you can get it. And they say rising tide lift all boats. But I say if you can help one person, just like one person getting COVID can exponentially spread it to 1,000. If you can help one person, you can exponentially help 1,000 people.
Yes. And that's the message we'll take to the State House.
Yes.
To get Medicaid expanded. Well, I want to say thank you both, Dr. Robinson, Dr. Bailey, for talking with us today, sharing your expertise. This has been very informative. Really appreciate your time. To everybody who's watching, remember you can write us questions. If you have any questions for us, you can go to our website, MedicaidMattersFlorida.org. I am one of the stories collectors for Medicaid Matters and for Florida Voices, talking with people all over the state who don't have access to healthcare, who have access to healthcare, but they can't use it because it's so expensive. People on Medicare and Medicaid, and talking about some of their experiences trying to use and access care. So if you would like to share your story with us, please go to MedicaidMatters.org/stories. We appreciate your time. Thank you so much.
Thank you.
Thank you.